All right, good evening, everyone. Uh, my name is Joe Heston. I'm one of the chiropractors at AIM Spine and Sport. Today, we're going to focus predominantly on a condition known as SAD, otherwise called seasonal affective disorder. And we're going to talk a little bit about depression because SAD is technically a subtype of depression, so it's kind of hard to talk about one without talking about the other one. So, a little bit of background about me. If you don't know me or you haven't met me before, uh, my name is Dr. Joe Heston, and oh, good evening, everyone. My name is Dr. Joe Heston. I'm one of the chiropractors at AIM Spine and Sport, and for today's webinar, we're going to talk about depression a little bit, and then one specific subtype of depression known as SAD or seasonal affective disorder. It's pretty common, especially this time of the year, and we'll kind of talk about why I suspect it's going to be more common this year, especially compared to other years. So a little bit about me in case you haven't met me before. Again, my name is Dr. Joe Heston. I'm one of the chiropractors here. Dr. Jesse and I actually went to school together at Palmer College of Chiropractic in Davenport. So that's how we've known each other since, let's see, I've been 2014. After I graduated in 2017, I ended up doing a 3-year residency in Illinois in the southwest Chicago suburbs, focusing on musculoskeletal radiology and diagnostic ultrasound. When I completed that residency, it just so happened that Dr. Jesse had an opening here at Ames Spine and Sport, and I applied, and thankfully I got the job. So I'm happy to be working. I'm originally from Dubuque, Iowa, though, so it's one of those things where people often say like, yeah, I leave Iowa, but then I find myself coming back, and that's definitely true for me. I left and now I'm happy to be back. An interesting fact about me that some people may or may not know is that I'm actually a triplet. So whenever I tell people that, they always ask, are you and your brothers look alike? Is it a boy and 2 girls or whatever? So here's a picture of me and my 2 other brothers and then my dad behind us. So I'll let you be the judge if we look alike or not. And just a quick disclaimer, this presentation does not replace a physical exam or an appointment with a board certified physician and is only here for educational purposes only. So quick overview of what we're going to talk about tonight. Basically, we're going to talk about the seasonal affective disorder, but as kind of an introduction, I'll go over hormones and how they relate to different moods that we have. Something that is often kind of confused between people and confused me before I learned about it more was hormones versus neurotransmitter. Are they the same thing? Or are they different? And then what balancing act do these hormones have in our body and how they attribute to moods? A lot of these chemicals have to be in certain concentrations and they have to be higher than other hormone concentrations. And when you start messing with specific levels and specific ratios, that's when you can start to have problems arise. And kind of a, excuse me, kind of a classic case that we talk about with this are, for those of you that are a little bit older, you might remember there was a wrestler and movie star in the 80s named Andre the Giant, who was a very large man. And the reason he was so large was he actually had a benign pituitary tumor at the base of his brain. And why that's important is that the pituitary gland produces a hormone called growth hormone. And as you can imagine, growth hormone causes things to grow. So in people without this tumor, the growth hormone releases exponentially when you hit puberty. It's actually one of the signs of puberty where you grow taller, you kind of fill out more, and you essentially become an adult. But once you hit skeletal maturity, that hormone should basically not be releasing as much as it had been during puberty. In his case, because of the tumor, it kept on releasing and releasing and releasing, and that's why he grew to be so large. And again, it's a very delicate balancing act. And in patients that do not have disease, it's very tightly controlled. Now, some patients, like Andre the Giant, had a tumor so that they couldn't control that. A lot of patients that have thyroid problems or benign thyroid tumors, that messes with different thyroid hormones and things like that as well. We'll kind of talk about how all these different hormone levels and specific hormones and what they do in terms of how do they relate to depression, or is it that specific hormones are too high or specific hormones are too low that causes depression? And is there any other kind of causes of too high or too low hormones? And then we'll specifically go over SAD, also known as seasonal affective disorder. And then they actually have a newer name for it that's mood disorder with seasonal changes, which is just a mouthful and it kind of downplays SAD. And we'll talk about that a little bit, including the causes of it, what are some signs and symptoms to be aware of, different treatment options, and then how we can help here at AIM Spine and Sport. So on this picture over here, just to kind of give you a quick summary here, I'm not sure how familiar people are with anatomy, but basically what this is a diagram is, it's of a synapse. And synapses are found mainly within our central nervous system, especially in the brain and nerves and things like that. Now to kind of make this a little bit easier, think of a synapse almost like text messaging, where up here at this top, the sort of mushroom thing, that would be like my phone. And say I wanted to text Dr. Jesse something. So all these little green things that we see here, these are actually like the text messages. So once I hit send, the actual kind of chemicals or text messages will go out into this space, aka kind of the world, if you will, and it'll make its way until it finds Dr. Jesse's phone. And once it finds the phone, it can deliver the message to her phone. So Dr. Jesse's phone is like kind of down here. So that's the kind of the main thing to understand with the synapse, is that we're releasing these hormones kind of within this space. They cross the space, they go to the other side, and they kind of relay the message down to someone else. And you can have these synapses that go from the outside of your brain to the inside of your brain, and then another one from the inside of your brain to your spinal cord, and then another one from your spinal cord actually out into the nerves that control your arms and other organs and things like that. They're just throughout the entire central nervous system. And these little chemicals here, they're often referred to as neurotransmitters when they're actually involved within the synapse of the central nervous system. But really, they're essentially the same thing as hormones, and they function very similar to hormones. So tonight we're going to go over every single pathway and different hormone on this chart here. Of course, I'm just kidding, but I have this kind of image up here to show you that how many different pathways and different organ systems are kind of influenced by hormones. And kind of the classic example I usually like to tell people is, if you look at the head here, here's the brain. And at the very bottom of the brain, there's this teeny tiny gland that looks like it's pretty insignificant called the pituitary gland. But if you look at all these hormones that are coming off of it, all these are extremely important hormones. You have ADH, which controls kind of our water balance, which directly is related to kidney function and blood pressure. We have oxytocin, also controlled by the pituitary gland, which is important for not only contractions in labor, but it helps form social bonds between, say, a mother and her child, or a spouse and their partner, and so on and so forth. Very important for social bonding and kind of that happy feeling you get when you haven't seen your significant loved one for a long time, and then like you see them at the airport, just that rush of emotion. That's attributed partly to oxytocin, among other hormones. You have important sex hormones like follicle stimulating hormone and luteinizing hormone to help with conception. You have important stress hormones that can also regulate, when you're stressed out, what kind of physiological manifestations from that, and so on and so forth. And of course, growth hormone, which we talked about a little bit before. But again, just kind of look at this and understand that that's kind of the nice thing about hormones is that hormones can be released into the blood. And once it's in the blood, it can travel throughout the entire body. And that's important for something like growth hormone because the pituitary gland just essentially dumps this hormone off into the blood and it can actually cause different effects throughout the entire body. It doesn't have to specifically have like a direct connection like the nervous system does in order for things to function. Now, the other example I like to talk about with this is I'm sure people have heard of adrenaline, where you have that adrenaline spike where you're, like a fight or flight mechanism where, say, you're at the bank and someone comes in and now they have a gun, and now you have to you have to think, do I stay here or do I run? And what happens? Well, your heart beats faster and almost feels like it beats out of your chest. You take deep breaths in and out because you're trying to increase oxygen, and you start to sweat too. That's considered kind of an autonomic, sympathetic response. And the reason that happens is because once your brain detects the stressful environment and initiates a fight or flight response, when you have all that adrenaline dumping, it causes the change because if you have to run, you need as much oxygen to your muscles so you don't get tired. Well, how does the body do that? Well, it increases breathing in and out, so there's more oxygen available to the blood. And then it pumps the blood faster throughout the body so that there's more oxygen available to the muscles. So that's part of that fight or flight response. But again, it's made that way because all the kidney, specifically the adrenal glands on top of the kidneys, all they have to do is start dumping adrenaline into your body, and then all those effects happen. It does not require that specific neuronal connection like a synapse would. But again, multiple stuff going on all over the place. And that's kind of the benefit of hormones is that you can get a big message out just using the blood. You don't need those specific connections. And kind of like what I said here, the nerves, you really have to have a synapse from the top of the brain to the middle of the brain, then another one from the middle to the cord, then another one from the cord to like your brachial plexus or lumbar plexus down here, and then another one actually depending on where you want to go. But with the endocrine system, the hormones, you basically just throw it out there, and if certain cells have receptors to recognize it, then they're able to actually get in there and detect it. If they're not able to recognize it, then basically the message just kind of passes along and no harm, no foul. So a little bit slower, but it can get to a wider audience, whereas the nerves are a lot faster, but they're only specific. If it does not have that direct connection, the actual message cannot get out. Okay, and I'm sure you've heard Dr. Jesse or myself mention this in the past about how, everything's connected, it's all related. So say we have a patient that's coming in and, they're feeling a little bit anxious or they're having depression or insomnia. And then we adjust them and they feel better. If they feel better and they're having less anxiety, depression, or insomnia, that means the neurotransmitters and cytokines are working better within their immune system. So they're not going to be as sick as often, and their body's going to be able to respond accordingly to different pressures and kind of different environmental factors like inflammation, infections, even allergies and pain. And then if that's functioning properly, that'll also cause the endocrine system to function properly as well. So this whole thing here is like a three-legged stool where all these components are just as important with each other. And if you kind of upset any one of these, it can cause upsets of the other two. And stressing can be physiological stress, emotional stress, environmental stress, and even physical stress. So, I mean, it's a very temperamental kind of balance, and it can be pretty tricky to keep. But luckily, there's systems in place within the body that tries to keep this order generally maintained. And like we'll talk about later, it's all connected. So there's again multiple hormones we can talk about. Within the body and how it relates to depression. But kind of the main ones we'll focus on right now are norepinephrine, also called noradrenaline, serotonin, and dopamine. So serotonin is the one that usually gets most of the blame when it comes to depression and kind of happiness in general. Serotonin is actually usually found in your GI tract, like your gastrointestinal system. So it's actually attributed to if you eat a lot of carbs and kind of feel that euphoric kind of happiness after eating a lot of carbs, that's mainly attributed to your serotonin levels increasing. And serotonin is kind of a good hormone to have when you're feeling pretty relaxed, you're not dealing with too much emotional stress or anything, it's going to be in relatively high levels. Norepinephrine, on the other hand, or noradrenaline, is basically kind of the opposite of serotonin. This is the guy that, if I go back to my earlier scenario about you're sitting in the bank and someone walks in and tries to rob the bank, and initially your heart beats faster, or you breathe in and out faster, and you sort of have that, do I stay here or do I leave, that fight or flight mechanism. That's basically your body dumping norepinephrine and noradrenaline into your body to cause the increased heart rate, to cause the increased breathing. And when this guy is out of control, it kind of minimizes the effects of serotonin. And that's kind of an important thing to remember, is that, again, all these guys have to balance each other at relative ratios to have certain moods. So if you want to be a fairly happy-go-lucky mood, serotonin will be high and norepinephrine will be low. But if you want to be in a I need to fight someone or I need to get out of here as fast as I can stressed mood, you need your norepinephrine high and your serotonin fairly low. Dopamine is also fairly important. It's kind of in the same class of serotonin in that its effects can usually cause sort of happiness or social bonding. But the problem with too much dopamine, this is the one that's usually attributed to certain types of addiction, where if someone has an addictive tendency like alcohol or gambling, that sort of high that you get while you're drinking or while you're gambling, that's considered, or that's usually attributed to dopamine being dumped into your system to kind of give you that sort of, dopey euphoric feeling. And although it can be attributed to other things, even like appetites and intuition, again, you need a balance between all three of these depending on the mood to have the desired effect. So, like I attributed to, the balancing act is the important thing. So, if we look at this, I actually like this graph over here, it's pretty nice. So, in a patient that's happy, the green guy is pretty much filling up the entire tube. Well, that's serotonin. That's one of the kind of happy ones. Whereas if they're suffering anxiety, that's very low levels of blue. Blue is dopamine. So if they have low levels of dopamine, it means that norepinephrine and adrenaline are pretty high, or cortisol is also high as well. And those are, again, the stressful hormones, fight or flight. I need to make a decision. Should I stay or should I go hormones? And then if we go over here to depression, we'll see that blue and green are both low, and that's dopamine and serotonin. Whereas kind of love, either love for a partner, love for a child, things like that, that's all high levels of dopamine, serotonin, and again, oxytocin, which is the main chemical we think for social bonding. Then the fight or flight, like we talked about before, that's going to be our norepinephrine or epinephrine, also known as adrenaline or noradrenaline. So, speaking of all this fun, let's talk about how wonderful 2020 was this year. And by wonderful, I'm being sarcastic. We've had things like COVID-19 that's still going on. The 2020 election is officially over, but it was a pretty crazy election, craziest one I've ever been or seen. And then either high unemployment or financial instability, either for us or loved ones and patients we know, and then even the isolation associated with COVID-19 and other things. But in general, there's been lots of changes this year. And, if you look at any one of these, you could argue that, maybe one would be enough to, kind of make me feel down to the point where I might become depressed. But when you start to think about everything that we've gone through this last year, it's not unreasonable to think like, yeah, last year was a pretty down year for a lot of people. And now that we're in 2021, it's curious to see what effects 2020 will have on the 2021 year. And if you're like me, I'd rate the year 1 out of 5, maybe even half a star, not necessarily 1 out of 5, but definitely would not recommend. And kind of some statistics I found, one's from the CDC, one's from the state of Iowa. So this is just late June of last year. So this does not even include July through the rest of the year. 40% of adults in the US reported struggling with mental health or substance use. And this is important because declining mental health and substance abuse are both considered kind of risk factors for developing depression and other kind of depression-like syndromes, including seasonal affective disorder. And if you look at these numbers and you kind of put them in a better perspective, it's just crazy to me to think that, almost 1/3 of patients in June of the US are reporting, anxiety or depression symptoms, or over 1/4 of patients report as trauma or stress-related disorder. And then, what scares me the most is down here at 11%. Think of every 10 people you know. Of every 10 people you know, there's a chance that one person has seriously considered suicide. Not necessarily just suicidal ideation, but they've actually thought it through and have contemplated it. And that's probably the scariest statistic of that to me at all. I wouldn't think it would be anywhere near 11%. And again, this is just June. We don't even know. This was the most recent update I could find for this. And again, if we look at the suicide facts, and this is from 2018, so this doesn't even really take into account COVID-19 or, isolation or any of the other things we've talked about. So in 2018, suicide is still the 9th leading cause of death in Iowa. And, this isn't some other state where like Illinois, where there's a higher population. This is Iowa. So these are, people we see, people we interact with every day. And, when I looked at the stat, I was almost blown away by it. On average, one person dies every 19 hours in Iowa, not in the US, in Iowa. So it's definitely something that we should try to be more vigilant in recognizing both in ourselves and in our loved ones as well. Okay, so now we're going to kind of actually talk about the seasonal affective disorder. This used to be referred to as the winter blues, and this name just really bothers me because it almost seems like it's kind of downplaying the seriousness that should be attributed to seasonal affective disorder, like, oh, it's just the blues, it's just during the winter, it's really not that big of a deal. Well, it's a subtype of depression. And as we know with depression, if depression is prolonged or depression is untreated, it leads to suicidal ideation. And if the suicidal ideation is not treated correctly and it's even further prolonged, that can actually lead to suicide. So it's an important thing that we need to cut it off and essentially recognize it as soon as possible, like with anything, to give the best prognosis for ourselves and patients and loved ones. And, the term winter kind of makes you think like, okay, so it only happens during the winter, but it can actually happen any time of the year. And what can make it even trickier is that the symptoms can actually change depending on the time of year, where we think about depression as overeating, not wanting to move, kind of down in the dumps. But during the summer months, signs of seasonal affective disorder, which I'll show on the next slide, is actually loss of appetite and not kind of an inability to eat and being very irritable. So it's kind of the opposite of what you would associate it with, but it's still part of the condition. As far as the symptoms and signs go, it's really kind of like almost any type of depression that you might be familiar with. Kind of withdrawn from society, low energy, could be insomnia, but then it could also be sleeping too much. So could go either way on that one. And mood swings. Sometimes they have low lows, but then they might have high highs. And sometimes that can actually be misdiagnosed as sort of a bipolar or schizoaffective disorder. And then again, overeating, especially if it's more kind of the winter type of findings, but if it's more summer, then it's actually loss of appetite and not eating as much. And to be aware, something to be aware of is that, depending on the research you look at, it is 4 to 10 times as common in females over males. So definitely something to be kind of more vigilant of noticing, especially if you have female loved ones and coworkers, just because it's, almost 10 times as common depending on the research you read. And again, the DSM-5, which the DSM is basically where psychologists and psychiatrists come up with inclusion criteria for different conditions and disorders where, if a patient is having symptom A, B, and C, it's condition, 1. But if they're only having symptoms A and B, then it's actually condition 2. And they've had 4 or 5 revisions of this. So DSM-5, I believe, is the most current revision. It came out in 2013. And unfortunately, it doesn't even list seasonal affective disorder like the previous ones. It actually just calls it a mood disorder with seasonal pattern, which, again, I'm not a fan of because that almost sounds like it's downplaying it as, okay, it's not really depression, it's just a mood disorder, but it's actually a subtype of depression. It's 5% of people in the U.S. are going to experience it. 10 million people, and then 4 out of 5 people on this stat say females, but again, I've seen stats that show it as high as 4 to 10. So even though unfortunately it's kind of downplayed, and even though there's a negative kind of connotation or stigma with mental illness in the U.S. and depression, it's still something we collectively have to be vigilant of and trying to recognize. So, like I alluded to before, you can have seasonal affective disorder. Everyone thinks the classic winter symptoms, you eat too much, gain too much weight, and more sleepy and depressed than usual. But in the summer, it's almost like I said, the exact opposite. And, irritability instead of depression, insomnia instead of sleeping too much, and so on and so forth. So it's important to recognize these. And if you're looking at this and you're saying, well, how do I know that it's seasonal affective disorder and not just, depression? Well, kind of the main point is that with depression, pretty much unless you treat it or unless it's being handled appropriately, depression is pretty much going to be there throughout the year, especially if it's not being treated correctly. It'll kind of be there and then get worse. Traditionally, with a seasonal affective disorder, it'll get worse at specific times of the year, but then it'll get better at later times of the year. So that change that matches the seasons is kind of the crux to make you think seasonal affective disorder versus just depression related to something else. So specifically, what's causing seasonal affective disorder? Again, there's not much research really specifically attributed to trying to find the cause for this because, again, most people unfortunately kind of downplay it and think, well, if I can just get you through the winter, you'll be fine. But what's believed to be happening is that in the winter months, we're not outside as often, or when we are outside, we're pretty much covered up most of the time, especially if you live in a more northern hemisphere, like especially here in the Midwest, where there's seems like there's snow on the ground half the year. What happens is when you don't go outside, the UV, or excuse me, the sunlight is, when it hits your eye, the the eye actually sends a message to your brain, specifically the hippocampal region, that says, hey, there's sunlight out. And then this message sends another message to specifically the pineal gland, which is a small organ gland that's basically kind of at the posterior inferior part of your brain. And that gland produces a hormone called melatonin. Now, melatonin is an important sleep hormone. During the day, when there's sunlight out, you have extremely low levels of melatonin and you feel pretty much awake, ready to take on the day. As the sun goes down and there's less and less sunlight hitting the eyes, this message again gets relayed to the brain and then to the pineal gland that says, hey, there's less sunlight out here. So once that happens, now the pineal gland starts pumping out melatonin. And the melatonin in increasing levels is going to slow down your heart rate, it's going to slow down your breathing, which makes you sleepy. And it kind of gives you the clue, okay, it's nighttime, I'm tired, I'm going to go to bed. And that kind of melatonin levels and affecting our sleep and daylight is kind of referred to as that circadian rhythm, where when we're sleeping in our bed and the light hits us in the morning, it causes us to wake up. But when it's dark out, when we lay down, it causes us to fall asleep. And why this is important is because light will decrease melatonin, but light will also increase serotonin. And since serotonin is the main hormone we think of that is being attributed to depression, if we can keep the serotonin elevated, or another way to think of it is if we can limit the depression of serotonin, that's going to limit the likeliness of developing depression. So what are some things that we can do to help with seasonal affective disorder? Well, you might intuitively be thinking, well, if I go out in the sun more and I can increase my serotonin levels, I can decrease melatonin, that would be helpful. And yeah, absolutely, that's the main thing. It's trying to get out and actually expose yourself to the sun, especially getting as much skin exposed as you possibly can. Now, I know in Iowa in the winter, that's really not ideal because it's, yeah, I'm making vitamin D, but now I'm getting frostbite. So obviously we don't want you to do that. But that's where, especially if you live in the Midwest and you're Caucasian, it's a lot harder to get vitamin D than if you were kind of in the along the equator or kind of in the southern United States where it's a lot easier to get more sun. So supplemental vitamin D is going to be a huge thing for us here. And what's interesting is that there's actually receptors in the brain for vitamin D as there is for serotonin. So vitamin D and serotonin actually have similar functions. And then if I increase vitamin D, I will also increase serotonin levels. And if we, as we know, increase serotonin, we actually decrease depression. And an article I actually found that was really interesting was that there's kind of a causal relationship right now between vitamin D increase and Alzheimer's. Now, it still needs further research to kind of confirm these findings, but what they've noticed is that patients that have higher levels of vitamin D in their blood are less likely to developing Alzheimer's later in life. So whether that's just a simple, who knows why, or if it's an actual thing to be aware of, I think it's definitely worth studying. And the cingulate cortex and the hippocampus that also have vitamin D and serotonin receptors, those are important centers in the brain for memory function, emotional stability. It's part of the limbic system. So all these are kind of important factors that seem to all deal with serotonin and vitamin D. If you can't get outside, then a light therapy is also recommended. And I'll talk a little bit on the next couple slides about a light box is what it's referred to as, but essentially you're trying to mimic the same logic as either getting vitamin D, although vitamin D requires UV light exposure in the skin to actually start the process. But like anything else, if you have too much UV light, now that's a risk factor for skin cancer. So it's like anything else, you got to find that perfect balance. And then pharmaceuticals, there's different ones out there. I'm not going to talk too much on that. But when I was in chiropractic school, one of my jobs was in school that I was a pharmacy technician at Hy-Vee in Dubuque. And I'll tell you, SSRIs are one of the most common medications prescribed. And not just for depression in general, it's probably, I know when I worked there, it was one of the top 10 medications we dispensed just at our pharmacy was SSRIs. That's like fluoxetine, citalopram, things like that. And then finally, psychotherapy, which is, just talking to a psychiatrist or psychologist or psychiatrist. So here's an interesting paper I found. What they did was they tried to assess if supplementing with vitamin D would have any effect on the patient's own perception of depression. So what they did was they took two groups. So in one group, which is the placebo group, they gave them no vitamin D. So the blue level is what their blood levels of 25 hydroxyvitamin D, which is the inactive form of vitamin D. And then the green bar is basically an outcome assessment where they would have the patient fill out paperwork rating, like, how depressed are you? Have you ever thought about suicidal ideation? And then they would come up with a score and they would kind of report it. So in patients that received no external vitamin D supplementation, their vitamin D levels didn't change much. If anything, maybe decreased a little bit. And, their actual outcome for depression, a little bit of a decrease, but really not much of a significant change. Now in the second group, if you kind of compare their week 0 to the first group, maybe a little bit higher vitamin D, pretty much the same actual kind of outcome for depression. But then 2 months later, and this group was receiving supplemental vitamin D, now their vitamin D level is through the roof in a good way. It's not toxicity or anything, but it's increased. Look at the significant difference between their kind of self-reported depression. And this is only in 2 months. And all they did for these patients was give them supplemental vitamin D. So it does give some support to the notion that vitamin D and depression have an inverse relationship, where if you increase vitamin D, you're likely to decrease depression. Whereas if you have vitamin D deficiency, it might increase your risk for depression. So here's kind of the light box I was talking about before. Again, there's multiple options out there, kind of some things that are recommended by Mayo. Try and find a box that uses as low a UV light emittance, which it should say on the box. Again, the higher the UV, that has a correlated risk with developing skin cancer, so they want to keep it as low as possible. And then with light boxes, the unit they use is called lux. So it's basically kind of how intense the actual light is. You want something kind of around 10,000 lux, maybe a little bit higher. You basically start the treatment for 20 to 30 minutes as soon as you wake up. And like this person here, sit a couple feet away and have the light basically just shining on your eyes. It's basically like an artificial sun. So just like you wouldn't stare at the sun, don't look directly at the light, but you can have like an iPad or the TV on, or in this case, a book reading. And as long as the light is hitting your eyes, that's sending the receptor to your brain saying, hey, there's light outside, and that sends the receptor to the pineal gland that tells it to stop producing melatonin, and that should also increase serotonin production. Unfortunately, these things are usually not covered by insurance, but I just took a quick peek on Amazon, and they're running in the $20 to $50 range, so not horribly expensive. And then with the SSRIs, which again, this is the pharmaceutical approach. I'm not going to divulge too deep on this one, but kind of the main thing just to be aware of with these medications and how they're attributed to reducing depression is, well, if we think about that normal synapse where, again, over here is my phone, down here is Dr. Jesse's phone, and then these are little text messages that we like to send between each other. So as long as the serotonin in this case is kind of in the gap, it can actually, or the text message can actually go across and let Dr. Jesse know what's going on. Now, over time, as these sit within here, they eventually degrade and are broken down by other enzymes whose sole function is to break these down. Because if you have all these messages right here and the body needs to send a different message, so say the serotonin is all over here, but now all of a sudden the body wants to actually send out norepinephrine, it's kind of hard to do it when you have all this clutter right here. So that's the whole function of the enzymes, is that they break these down. But if the levels get too low, the person's clinically depressed. So what we can do is we can actually block the enzymes from breaking these down so that we have kind of a, not abnormally high, but we have a higher amount of serotonin within the gap, which allows the patient to feel less clinically depressed. That's kind of the whole gist when it comes to the SSRIs, which is selective serotonin reuptake inhibitors. So these are just some common side effects I'd kind of throw out here just so everyone's aware of light therapy and SSRIs. Again, nausea, insomnia, diarrhea, headaches, pretty common with the SSRIs. Less common ones would be reduced sexual side effects like a reduced libido and dry mouth. And then light therapy, eye strain, obviously, because you're shining, a bright light in your eyes. Headaches, same reason. And then kind of some variable symptoms with nausea and things like that. So if I go back to this, how can we help? Well, the main thing that we can do here at Ames Spine and Sport is help really reduce as much of your extrinsic stress as we can. Whether that be chiropractic adjustments, the trigger point therapy Dr. Jesse and I will do, Dr. Jesse's acupuncture, or Brooke and Liz doing massage, things that help make you feel better. We can remove some of this stress. We can actually allow these three systems to communicate better with each other and equalize appropriately. And kind of something I like to point out is, even coming to your appointment, it's getting you out of your environment, out into the sun, getting some sunlight exposure, and, just coming into our office and interacting with us, interacting with other people is, kind of taking away from isolation. That's also in itself a form of therapy. And especially me, I know whenever I get adjusted, I always feel better afterwards. And again, that's that serotonin kind of increasing following the adjustment, which, makes everyone feel better. And, me personally, not to boast too much, but I think I'm a pretty good listener. When you grow up as a triplet, there's always two people fighting. So you kind of have to sit back and more or less enjoy the show. And I do like to listen to other people. I'm more of an introvert actually than an extrovert in general. So I usually like to sit back and kind of see what's going on. And I think one thing that we especially do very well at our clinic that normally you don't see at other clinics is we like to take the time to get to know all our patients, and we like to communicate with them as often as possible. And why I like to do that is because we like to kind of gauge what a person's general kind of mood is. And that's important because if all of a sudden their mood is different than what we were expecting it to be, that's kind of a flag for me or Dr. Jesse or Katie or Liz or Brooke to say, yeah, something's not right. What's really going on? And I actually had this happen a couple weeks ago where a patient came in and they're always pretty joyful, happy. They laugh at all my jokes, even the ones that aren't funny. But then they came in and very subdued, very reserved. Just yes or no questions. And I looked at him and I'm like, so is everything going on? Is everything okay? And they're like, oh yeah, everything's fine. I'm like, I don't know if I believe that. What's really going on? And they ended up, breaking down and, I don't want to say anything, but I mean, they were very stressed and they were going through a lot, and, they felt better just releasing instead of bottling it up. And, again, I think that's one of the things that I like about our practice, at least, is because we try to take the time to know everyone, and then to listen when we have to. And I'm not going to say that, I'm not a psychologist or psychiatrist, nor do I pretend to be one, but at the very least, I can at least recommend someone to you that would be more effective in you seeing them than just coming and talking to me. And I think that's the important thing is, I know what I know, but I don't know what I don't know. And when it comes to things that are outside of my scope, if I can't do it, I find someone that can do it better than I can. I think that's the important thing. Whereas if you go to some other doctor's offices, and it seems like you spend more time in the waiting room or with the nurse than you do actually seeing the provider. Unfortunately, that's the way it shouldn't be. So I'm glad that we're able to do that in our clinic at least. And it's always tough because most people, especially the older you get, it seems like everyone knows someone that's committed suicide. Myself, one of my best friends I knew him in kindergarten all the way through high school. He ended up killing himself a couple years ago, and you always kind of ask yourself after the fact, like, what were the signs? Was there anything I missed? Could I have said anything? And you know, you always second guess yourself on things like that too. One thing that kind of I used to say, if ever I was suspecting something was going on with someone, I'd say, okay, well, if you want to talk or you need something, just give me a call. But the more I thought about it, that almost kind of seems like a kiss off in some ways. So what I try and say now is that, I want you to know if you ever need anything, just call me or text me, whatever. And to me, when I say I want you to know, that kind of, in my mind, whether you think so too or not, it tells the person that, I understand you're going through something. I understand maybe you don't want to talk about it right now, but if you ever feel like you need to, please call me. Whereas if it's just, if you want to call me, go ahead, I don't care. So to me, it sounds more insincere. If not, you can do your own thing. I'm not saying that's the best or the worst. That's just what I do. But I think the important thing in recognizing these patients is at least being there and being willing to listen. Because half the time, no one's either paying attention or no one's willing to listen. So, kind of the final thing I'll bring up here is that if you or someone is depressed or might be having suicidal ideation, it's always important to kind of give them as many resources as you can. And this resource, the National Suicide Prevention Lifeline, it's toll free. You can call 24/7. There's always someone on the other end of the line that can help you directly or put you in the hands of someone that can help you as well. So again, it's a free service, and there's also a link down there, suicide prevention, on suicidepreventionlifeline.org. So either for yourself or for a loved one, it's never a bad idea just to kind of throw it out there just in case, because a lot of us think we know people, or okay, yeah, I would be able to tell if someone was depressed, or I'd be able to tell if someone was in a bad place, but you never really know what people are going through. So it's always good, again, just to kind of say, hey, I'm here whenever you're ready to talk. And I think that's the important thing, especially after last year and everything that's been going on the last couple of months. It's always good to let other people know that you're there and you're ready to listen. So I'd like to thank everyone for coming to this talk tonight. I know everyone has a busy schedule. If you have any questions, comments, or concerns about anything, please feel free to contact me or Dr. Jesse or anyone at our office, Ames Spine and Sport PLC, 214 Main Street, Ames, Iowa. And our number is 515-450-8541. So again, thanks everyone for coming. And I hope you had, I hope you learned a lot tonight, and I hope to see you around the office. Take care.